discipline during this COVID.
I'm sorry.
It became quite a complicated discipline during COVID, from what I've read.
Oh,
Yeah,
the whole healthcare delivery system is still under a lot of pressure.
a lot of pressure. Yeah,
I mean, it's been real tough on people.
yeah, yeah. I'm a retired nurse practitioner, and I retired just about the same time you did.
Yeah.
Yeah.
Did you feel a survivor's guilt? A little bit on my part.
Well, I think that was pretty common. I felt awful. I still feel awful for cohorts who are still working because they went through a lot, So
Yeah, I mean, that was February 2019, and then of course the pandemic really hit a year after that. But I thought, oh man, do I have to go back and help out the troops?
Yeah.
But I didn't think it was fair to my patients.
Yeah, I can understand that. That's for sure. I did a lot of, living in a very rural area, I got a lot of phone calls. So I was doing online advocacy to try and help people sort through what to do.
Sure. Yeah. Wow.
It was really, an interesting time. So, and still is.
It still is.
Yeah.
Should we get started?
Well, do you think we have folks up? Yeah.
Well, it's
Okay.
6:02.
Okay, well, we're going to start tonight's program. I'm Jan Penn, and I am with the League of Women Voters of Ashland, Bayfield County. Tonight's topic is a real hot item right now, as I'm sure most of the folks participating are aware. The League of Women Voters is known foremost for our work on voting rights and securing the right to vote, and also securing the integrity of that process in the democratic society that we live. But to be voting, you also need to be informed, and hidden behind that main goal of the League is the ultimate goal of helping our communities and become informed individuals, and then vote based on issues that are of great importance to us, but to know then what the candidates we're voting for, where they actually stand on these issues as well. So last month we did a little exploration of the Inflation Reduction Act, and we looked primarily at the climate-related, energy-related aspects of that rather complex act. And of course, all of us living up here are well aware that we're going through some really unusual changes in our climate, whether you're a gardener or a farmer or collect mushrooms. We see some changes going on. We live in an area as well. I just looked at some maps of the census, and in Wisconsin, about 17% of our population is over 65. And on this map I looked at that was various shades of blue, the northern third of the state is just solid dark blue. We have a much higher percentage in the rural communities of the north of elderly, seniors, people who have worked hard. And it could be said that the generation that has been moving into over 65 are the workaholics. I mean, folks up here worked many times. They were working multiple jobs to make ends meet. And, we're resilient folks up here, and have paid into our Social Security and Medicare plans as part of our retirement plan, because for many people, they did not have IRAs or access to union-sponsored jobs that facilitated a retirement that is maybe expected a bit more in some of the urban concentrations of those areas of our state. So tonight's program is the topic of Medicare and the privatization of Medicare and some of the things that are going on that pose threats to the health security that many of us as seniors have concerns for. And with the upcoming November elections, it's a big issue. It's a big issue. So that's why we're here tonight. And we have an esteemed crowd to join us here to understand what's going on with this matter. We have two folks from Milwaukee area, a retired physician who had worked pediatric emergency care. I'm sorry, I believe that's what it was. Emergency pediatric area in more intensive care with pediatrics, but is familiar with Medicare as well. And that's Dr. Mark Newman. And with him is Christy, who both of whom have presented throughout the state as part of their programs with the Citizen Action of Wisconsin. And then panel here tonight are all experts as well in the area of senior concerns and are the Ashland and Bayfield County Division of Aging workers. One is Amy Janicek, who's with Ashland County, and the other is Mary Ann Johnson, who's with Bayfield County. And they're going to give some response after the major presentation in PowerPoint and some observations and reflections on their work with seniors and issues that are common to the questions that are brought to them. And then Sue Setterholm, who's a retired social worker, dairy farmer of Highbridge and a good neighbor of mine. She also is going to reflect a little from her perspective, having retired from those positions, but also as a patient. So we'll kind of start, and as people you'll see these faces and you know, get to see who these people are as we go through this process of the program. So and there's going to be a question and answer period because that's how we learn. We listen and then we ask questions, and it's always a good format we found to provide ample time for that. So so with that, we'll start with the PowerPoint, and I believe Dr. Newman.
Oh, actually, I'm going to introduce Mark, and then he will have the PowerPoint.
Okay, great.
Okay.
Excellent. Go for it.
All right. Sorry. Hi, everyone. Thank you for having us tonight. You are resilient. My husband is from the Upper Peninsula. So I wore flannel in honor of you. 'Tis the season. And I just have to tell you, he makes me laugh because he always complains about how warm it is down here. And he talks like, it's almost like he's talking like he's living in Florida. So just living downstate feels a little more tropical to him. So I agree with the resilience part. So I'm Karen Kirsch, the campaign director for Citizen Action of Wisconsin. And of course, I have Dr. Mark Newman with me, who is a member of my Healthcare for All co-op, but he is also an esteemed member of the Physicians for a National Health Plan. He's very active with them as well. And yes, he is that kind of doctor, as you heard Jan say. He is a retired pediatrician. And I consider him one of the best speakers in talking about the privatization of Medicare. So, and of course, he works closely with me. So I asked that he join me in talking to you about this issue. So I'll start off by saying that Before I was a campaign director, I was a healthcare organizer. And in that role, I spoke to hundreds of people about their interactions and often harm from our healthcare system per month. So part of what Citizen Action does is we advocate and a little agitation as well for better healthcare policy and laws that will step us to a better healthcare system. So if anyone here has a family member that has a healthcare story or a lived experience from our healthcare system, please talk to me. I'll have some links that you can contact me or submit your story to me. Those stories help to link policy to the human experience and help people understand how our system in so many ways is still harming people. So we're looking for medical debt stories, Badger Care expansion stories. If you just missed qualifying for Badger Care expansion, or if you have a Badger Care, or if you have a family member that missed qualifying, if you have expensive prescription drugs, if you have an ACA story, please share it with us. We would love to hear from you. And it's an easy way to contribute to this topic. So again, it helps people connect the personal to the policy. So I'm going to assume, because you're here, that you recognize that the privatization of Medicare is actually a bad thing. And let's just go with that assumption. We'll take questions and discuss this at the end. But here's the proof of why I think that you might be right. So right now in the US, we spend more money per person than any other country, modern industrialized country, I should say. And we spend 20% of our economy on healthcare. And you might think, oh, well, we're getting the best healthcare in the world. Well, we are not. With all of that spending, we are actually not getting better outcomes. So we are not getting a value for all of this money. And not only that, we're not covering everyone. We still have people that are left out. One of the things that is also happening is that it's limiting people's freedom. Our coverage is often tied to our employment. I've had people tell me that they've gotten married for coverage. How's that for romance? I've had people tell me that they've gotten divorced for coverage. Okay. People are having to set up GoFundMes while they're in the hospital. So these are largely American experiences. And unfortunately, they're very bad American experiences, right? These are terrible things. So those other countries, they're not looking to copy our patchwork system of private, hybrid. Some of us are under public, some of us are on private. No one is looking to copy us. So that should tell you something, right? And they're spending less money and they're covering everyone, and they have better health outcomes. So they're living longer and they have better care. Okay, so they all have some form of a universal public system and are not largely privatized. So I feel like that is probably very strong proof that moving towards further privatization is not the direction that we want to go in. So Dr. Merck is going to talk to you about, so there's the obvious privatization of Medicare that a lot of you may know about already. You know what? My little dog is howling in the background. Let me just go grab her. I'm sorry.
Okay, well, then introduce Mark.
I'm not sure if we should wait for Karen to get back.
Let's
Oh,
not.
there she is.
I'm done.
Okay.
I'm done. I'm sorry. She's blind and she will
Oh.
not end unless I do something about her. Sorry about that. So, and I'm almost done. So, Dr. Mark is going to be talking to you about the private. So there's 4 parts to Medicare, part Medicare A, B, C, and D, right? And a lot of you are aware that Medicare Part C is Medicare Advantage, and it is a privatization of Medicare, but it's obvious to you, and a lot of you have weighed that choice of whether or not to partake in that. He's going to be talking to you, he'll touch on that briefly, but he's going to be talking to you about the privatization of traditional Medicare, which is actually Part B, and then obviously there's Part A, hospitalization, and Part D is the drug plan, right? But he's going to be talking to you about the behind the scenes privatization of Part B, and again, talking to you a little bit about Medicare Advantage. But I just wanted to share just like 2 brief stories about some things that are happening in the privatization of Part C Medicare Advantage, because like I said, I talked to hundreds of people and they have called me and told me their stories. And I thought you might be interested in this story because it's a community that is not unlike your own. So in Alexandria, Minnesota, there's one healthcare system there, and they're a little bit further away from any major population areas. So there's only really one network to choose from. And a lot of the seniors there selected Medicare Advantage, and I don't necessarily blame them. I understand the attraction. And that system changed over, it got bought out, which is happening a lot. There's a lot of consolidation, there's a lot of monopolies happening. And guess what happened? Part of Medicare Advantage is that you need to be in your network, otherwise you might get a sizable bill. All of a sudden seniors started incurring large bills and they didn't understand why. It's because that network was no longer in their plan. So that's something that can happen when you have the privatization going on. Now, if they were in traditional Medicare, you can go anywhere. That is something that would not have happened if they were in the other part of Medicare. The other thing that just happened recently is I had a senior call me. He's being treated for lung cancer, and he has a Medicare Advantage plan. And he is running into an authorization problem. And when I say a pre-authorization problem with his insurance company, so when I say pre-authorization, it's really code for the insurance company is deciding your care, not your doctor. So let's just like bring that out into the open. That's code. And his insurance company actually called the shots on his cancer care. His doctor wanted him to have immune therapy along with his chemotherapy, along with his radiation. And they said because it was a reoccurrence, they were not going to approve it. So most people don't have the resources to pay for that on their own. So a non-approval means he's not getting it. Okay, so that's something that happens in the private system. That would not have happened if he were in the traditional Medicare. And a lot of seniors are not aware of that. They just don't understand that that pre-authorization might be a hurdle that might snag them. And let's be honest, he's not receiving the care that his doctor wants him to. His insurance company called the shot on that. So I think that I've established with you that generally speaking, more privatization is not the direction that we need to go in. We have all these countries that are doing better than us, that have largely public systems and they're spending less money. We have examples of people that are being denied care in the private system. And I will hand it over. Oh, yep. Okay. I was going to tell you about one more thing. I just have to tell you because this is shocking. In Japan, Japanese citizens pay, in America, we pay $160,000 more for the same drug than citizens of Japan. It's a drug called Xandy, and it's for prostate cancer.
Mhm.
So we are paying $160,000 more than a citizen of Japan because that public system is also negotiating drug prices for everyone, not just its seniors. So I felt like that was a really important scenario that I wanted to give you because it's just so shocking to me. So, okay, so I will now hand it over to Dr. Mark, who has a presentation for you. I think that you will really enjoy his talk. And Dr. Mark, I do have your links as well. I took them out of your presentation, and when the time comes, I'll also drop them in the chat for you that people can easily link to. He has a petition for you, and he's encouraging you to write a letter to your editor. All right, Dr. Mark, take it away.
Okay, thanks, Karen. Are we good to go, Jan?
Yes, for sure.
Okay, all right, thank you. Thank you, Karen. First thing we want to do is see if we can get this share screen to work. We had it set up beforehand. And are we doing it? Is it working?
We're not seeing
It
it.
takes a minute.
Hold
It
on.
takes a
Hold
few
on,
seconds.
let's see here. Now,
There we
There
go.
we got it. Okay. Wonderful. Yes, so Karen just outlined some of the issues that we have with our current healthcare financing system in the United States. And what I'd like to do today is just give an insight into part of why we're where we're at. And we're going to talk about these two things called direct contracting entities, otherwise known as, also known as ACO REACH. It's a threat to seniors and the future of Medicare. So what I'm going to do is talk about what it is and what it matters for and what we can do about it. So our three whats. What is it? What matters about it? And what can we do? Okay, let's see here. Great. Now, I am a member of the Physicians for a National Health program. In fact, I just became a board member of this national program. And we believe 24,000 physicians that healthcare is a human right, and essentially everyone should be able to receive it with nobody out. So everybody in, nobody out. And because of that fundamental belief, the best way to get to recognizing and implementing that right is through an improved Medicare for All program. That means one nonprofit health insurance plan for everyone. It should be publicly funded, but this is the important thing. It's privately delivered. So it's the same doctors, the same hospitals, the same facilities that we have, but we're going to pay them for the services that they provide to us as a single payer. So that's just the background of where I come from and how I approach this notion of what we're going to talk about tonight. So the first question is, the first what is, let's get at it. What is it? Has anyone actually ever heard of these ACO reaches or these DCEs, direct contracting? First time I started hearing about this about a little over a year ago, it was just gobbledygook to me. And most people, it doesn't have any sort of real world attachment. When you hear those words, you say, well, what do they mean in real life? And even our congressional representatives were blindsided as this new program was coming out, because it was something that was not evident to the normal legislative process that gets debated in public, and it was appearing kind of out of the blue. And it came from a place called CMMI, the Center for Medicare and Medicaid Innovation. And it was a program that was permitted under the Affordable Care Act more than 10 years. It was embedded in that.
Oop. You're locked up.
Well, there's nothing he can do about it.
Yeah.
Movement or action to have it appear. So let's look at where this comes from. So this is just an organogram of the CMS, the Centers for Medicare and Medicaid. And it's under the direction of Xavier Becerra. And under the directorship of the secretary, there's the Center of Medicare and Medicaid Services, CMS. So it's under the Health and Human Services and then CMS. But under CMS, there's this other entity called the Center for Medicare and Medicaid Innovation. This agency receives $1 billion a year to consider ways of innovating payment systems for Medicare and Medicaid so that we would get better quality at a lower cost, but certainly not to cut back on quality and not to be something more expensive. And so it makes sense that there would be some type of way of always checking, can we do this better? Can we give better quality at a lower cost? Can we give better value? So that's where the program came from. It's called under the CMMI, Centers for Medicare and Medicaid Innovation. It was under the direction of Liz Fowler. In 2019, 2020, the CMMI, not under Fowler, but under the prior administration, the prior president's administration, came up with a new program under CMMI. They call it the Medicare Direct Contracting Plan or project. That program continued forward with the transition of administrations so that in April of 2021, it was actually implemented. And then over 21 to 22, so over that time period, where is coming out, but it was coming out in an unusual way because it didn't come through the normal pathway of being legislated on immediately with all kinds of review and public knowledge. And so in February so then there was a lot, as for example, my organization, the Physicians for National Health Program, as we became more aware of it, we began to campaign and illustrate this and alert people to the program and say, you better look into this. It may not be so good. And there was a lot of reaction and intervention happened so that by February of 2022, the movement and the organizers of the movement, so to speak, the catalyst said, you know, we better just change the name so that we can confuse people some more. So where before it was called designated contracting, it became ACO REACH, or the Accountable Care Organization. Didn't really change anything, but by putting a new name on the program and saying it's been reworked, it just confused the graph. In January of 20, the REACH, so it resulted, and it resulted in this timeline. So in order to get a better view of what these entities are, REACH and designated contracting, let's look at where Medicare came from. We can recall that in 1965 it was signed into law, and it was initiated in 1966 to give healthcare services for elders, and then as time went on, adding on for adults with certain disabilities. And Medicaid was initiated at the same time, administered through the states for people with decreased economic means. And over these 57 years, it has been working. People look forward to getting to age 65 because they feel like, you know, I'm finally going to have a health insurance program that I can rely that it's going to be there. And it's also been economically effective because the overhead costs are between 2 and 4%. So it's a program that's delivering the care, and it's not that much, not as expensive with low administrative costs. And most physicians by far accept Medicare payments today. So it's widely distributed, available to all. Original Medicare, the original program back in 1965, was a national program run by the federal government, therefore available to all of us across the country. It was publicly funded through payroll taxes and income taxes. So, you know, our Medicare payments on our W-2s and so forth. It defined benefits that were the same throughout the country. So all people were getting necessary medical care. There were no networks, no prior authorizations, no denials. There was no calling in to get an approval. There was no need to ask, am I in the network or out of the network? And there was nobody on the other end of the phone, as Karen just reported, talked about somebody saying, no, you're not eligible for that type of care. It was coverage that was under congressional control. So it was a public program, publicly funded, and available to all. That is traditional Medicare. Karen also talked about, as time went on, although the original Medicare was Part A and Part B, that was hospital care and outpatient or physician services, it was Part B. We've added on more things over the decades, so that we now have, since 2003, another program called Medicare Advantage. And then there's another program called Medicare Part D that allows for private insurance to get engaged in reducing the cost of our prescriptions if we're in the Medicare age group, in the older age group. But we're going to talk about particularly the traditional Medicare, Part B. But there are some gaps with that program that was initiated or developed, created in 1965. And even today, these are recognized as being important, criticisms of the traditional Medicare. For example, it doesn't cover vision or hearing, dental care, or long-term care. And the traditional Medicare implies co-pays, and there's high deductibles involved with it. And also, there's some criticism that Medicare payments to providers is low for necessary sort of ordinary care, but it does pay for procedures. And so it has a tendency to be willing to pay for expensive procedures, but to underpay the primary care. And then there's no limit of outpatient payments unless you buy a Medigap plan. So in other words, you don't have like a lifetime cap under the traditional 1965 plan. One of the ways of resolving some of those shortcomings is to, as we alluded to here, is purchase another insurance plan called Medigap to fill in some of those shortcomings so that it can fill in for your co-pays and your unlimited cap, depending on your Medigap insurance plan, in order to fill in some of the deficiencies of the original plan. Now, another way to solve that would have been just to fix the deficiencies. But instead of fixing the deficiencies of the original plan, we add on another layer and say, well, why don't you just buy an insurance plan instead of fixing the program to begin with? Then in 2003, we added on another program called Medicare Advantage. And currently in 2022, about 46% of our Medicare recipients, beneficiaries, are engaged in some Medicare Advantage program or another. And it is already projected that in 2023, it will be over 50% of Medicare recipients will be purchasing Medicare Advantage plans. But this Medicare Advantage is a privatization scheme. It allows for profit health insurance companies to manage the care of their beneficiaries. Medicare fund, but also some of the Medicare plans also have premiums that their beneficiaries pay for. And in the end, when it's studied, you realize that these programs, although they are able to sell themselves to beneficiaries because they say that they're going to provide for the deficiencies of the traditional Medicare, they end up actually being less efficient, more costly to the American pocketbook overall. And when studied more closely, they also are short-calling the care that's delivered, because under Medicare Advantage programs, you have to be a network, you have to get approvals, you have to do things that limit your care. And so more recently, there's been some more scrutiny being regarded towards the Medicare Advantage programs because of fraud. But for the insurance providers, the big insurance companies are on their Medicare Advantage program sales than they are with associated healthcare. Well, Medicare service, about 4% percentage of the actual expenditures for traditional Medicare are required for operating the program. Most of the expenditures go to the actual medical services that. But if you're in a Medicare Advantage plan, their medical cost ratio above 80 or 85%. In other words, they're only 15% an operation for taking profits and for managing the program. And the reason there's such an expenditure there is, well, profit taking is because they're a private organizations, and they have a fiduciary responsibility to their financiers to make a profit, but also because the programs, the Medicare Advantage programs, are so cumbersome in order to control expenditures that it costs a lot more just to run them. So there's a big discrepancy between an efficiently run Medicare traditional program and the Medicare Advantage programs. So I just wanted to give you that background because it helps us to see at least where we're beginning to talk about this new thing that we're going to call direct contracting that's evolved into the ACO REACH, into the REACH programs. Under traditional Medicare, so this is going from the what, now we're going to go into why does it matter, or what matters about this. Under the traditional program, the federal funds get sent directly to the provider. So you go to see your doctor, you go to see your advanced practice, and a diagnosis, services are given, and a bill is advanced to the government, and then it's paid back to the provider. Under direct contracting, we introduce a middleman. So it's, in some ways, it's looking a lot like the Advantage programs. You take, instead of taking money from the federal fund and giving it and paying out to the providers for the services rendered, we pay the funds to a middle manager who then designates how that money is going to be sent down to the beneficiaries, those that are covered under their program. And the theory here is that it's really risky to pay the providers directly because, you know, they just might make up stuff so that they can get more payment. And so that's the sort of the background argument, that you can't trust those providers to be able to make good decisions about the kind of care that is cost effective for the beneficiaries. And so we're going to put somebody in the middle who's going to be able to manage that care so that it's going to be higher value and less costly. And that's the theoretical justification for doing this. But these people in the middle, they want to make money because they are private entities. And once again, they have their fiduciary responsibility to make a profit for their investors. And how are they going to do that? They have three ways of doing it. They can increase the amount of money that they receive from the federal fund, and we'll talk about how they do that. They can try to decrease the amount of money that they have to pay out for actual patient care. So in other words, we're going to not pay for unnecessary care, but who's to decide, them or the doctor or the patient, what is necessary and what's not necessary? And so you do things when you're trying to make this scheme work, this business plan, take the money in and try to find ways to not have to pay it out. And the third way that you can make a profit as a middleman is to expand your enrollment, get more people on your roll, into your plan. And if you can do that, just volume is going to increase your profits, your benefits. So how do we maximize our revenues? And it's something called upcoding. So under Medicare Advantage and under these DCEs and REACH programs, you have to figure out how much money is the federal program going to pay to these middlemen to manage the care of the beneficiaries. And so they call it a capitation. They say you are going to get so much money for Mark Newman's care this month, but how do we know how much money Mark Newman needs in order to have good care provided to him? Well, we use a way of scoring. So we look at your diagnoses that you have in your medical record, and we say, for example, because you're at age 76, you're going to get a score of 0.45. And these scores, they're called HCC scores, another fancy name, hierarchical condition categories. But anyway, you might have type 2 diabetes, so we're going to be a 0.104 scale, and you might have some congestive heart failure, so we're going to give you the 0.323 scale. And then we add these all up, your total risk then is 1.03. So this would be kind of an average elder who could have some congestive heart failure, a little diabetes problem, and so on. And based upon a scale, then the capitation fund that is given to the middleman will be $9,000. And they say, with that $9,000, you should have all that you need to take good care of this individual. But if you can upcode it, if you're the person in the middle and you say, well, you know, when I looked at that patient, I said, you know, there was a little obesity. No, it was morbid obesity. So we'll just upcode it a little bit. We'll give it a bigger number. And you know that type 2 diabetes, we look in the eyes and we try to convince ourselves that there's retinopathy. And so now it becomes a new code, much higher. Or we say, you know, the person was a little depressed, you know, it's hard being elderly, you know, but now we're going to say, well, add on, had a single episode of major depression, and so we're going to get a score. Well, anyway, you can do that. You can play these tricks by, and there's actually an industry on how to look at the diagnostic procedures and coding so that you can make the patient look sicker so that you'll get a higher capitation fund. And this is just really basically fraud, but it's hard to control because who's actually seeing the patient other than the doctor? And so it's hard to control whether or not the accuracy of the diagnostic coding is being done. For the physician, it really doesn't matter. These codes are just sort of superfluous. But for the financier, it's real important to try to upcode them, make the patient look as sick as they can, even though it's not going to change anything that's going to happen specifically for the care of the patient. But the middlemen will get more money. So that's the way you can get more money. How can you minimize your revenues? How can you minimize those that are spent? Well, we're going to do the same thing like we do with the Medicare Part C, the Advantage programs. We allow the middlemen to orchestrate how much is going out. It offers a dangerous incentive because the middleman is oftentimes these entities could have some control over the physicians, maybe even giving them some sort of profit sharing, so that they are have an incentive to ration the seniors' care, saying that, well, maybe we really don't need all of that extra diagnostic test, and maybe we don't really need to send you to a specialist because I'll just handle it myself, because the specialist is going to cost my direct contracting organization more money. And so it's a dangerous incentive to decrease the quality of care to the beneficiary. These financial incentives, they just don't exist in traditional Medicare, because what advantage does the physician have to not make a referral if that's what's good for the patient? Or what incentive does a private care provider have for not providing the best care, because they're going to get paid for their diagnostic and care planning, and the patient will get the care that they need. All right, well, that's how you make it work. And then the other way to make it work is to recruit people to get into your program, and by aligning patients into the DCE in a way that they really don't even know that they've been aligned. Because instead of encouraging the patient to come into the program, what the DCE does is it identifies physicians and physician groups and organizations of physicians, and saying, now you're a contracting entity, and all of your patients are automatically aligned. They send a letter to the patients and say, well, you've been aligned to this new program, but it's not going to change anything. And in fact, it's probably going to give you some advantages. And because it starts off as nothing really changes for you, it doesn't alert the patient that anything different has really happened. And many times the physicians, if they're in a large organization, they may not even know that their organization became a direct contractor, because they're going to see the same patients and be doing the same care. And all of a sudden, they have become a designated contracting organization physician, and they really maybe even didn't know it. Well, I mentioned earlier that because the DCEs came out in 2021 and there was a grassroots concern for them, that caused an upswelling of concern and communication with legislators and pressure on the Secretary Becerra of Health and Human Services. And when that all happened, they said, well, let's just change the name. We're gonna tweak a couple of things about the program, and we're going to call it something else. But ultimately, it really didn't change the backbone of the program, because when you compare the DCE model with the REACH model, they both place a third-party middleman between the seniors and the care they need. Both of these programs entice private equity and other Wall Street investors to participate. Both allow middlemen to keep, well, this one actually allows them to keep up to 40%. Instead, we talked about Medicare Advantage being allowed to keep up to 15% under DCEs and REACH. You're allowed to keep up, you're permitted to possibly keep up to 40% of your what you receive in capitation. Automatically enrolls seniors. Both programs do that when their providers become DCE associated providers. Requires the seniors to change their primary care doctor. If your physician is a member of an organization that becomes a DCE provider, then the only way you can get out as a patient is to say, well, I want to change physicians, because all the patients of that physician receiving Medicare will be in the DCE program, and eventually come January 1st in the REACH program. And both of the DCE and the REACH can potentially align up to 30 million people of current traditional Medicare beneficiaries. So that's very attractive to private equity, because there's money to be made here, and there are a lot of traditional Medicare beneficiaries. If we can just get them into our program, we can make a lot of profit. I alluded to the fact earlier that traditional Medicare is efficient in its operation. Medicare Advantage not as efficient because it allows up to 15% of profit and overhead loss relative to what is actually distributed in patient care monies. Theoretically, now this may not happen, but it is at least under the way it's produced, theoretically, a well-run reach program, reach middlemen, could potentially keep up to 40% of overhead and profit. Now, I have to couch that, like I said, because these are new programs and they may not be as efficient, as capable of keeping that much money, but at least under the program, they're not limited to keep it, like 15% overhead, like they are under Medicare Advantage. So why is this a threat to our Medicare, traditional Medicare? When the program was being advertised and brought out, the CMS was the Centers for Medicare and Medicaid Innovation were representing to those who are interested that our aim is that by 2030, all beneficiaries of traditional Medicare will be under one of these programs because they're so great. And so that really illustrates the intention of these programs to expand until the whole system becomes privatized through a middleman operation. Money from the federal government goes to the middleman, who then distributes it or manages the distribution to the beneficiaries by taking off profits if they can. There are almost 65 million people receiving Medicare in our country. There's still about 35 million who are in the original Medicare program and 29 million who are receiving Medicare Advantage. But this has been moving in the direction of more Medicare Advantage. And as I mentioned earlier, up to 50%, those numbers are expected to flip in 2023. So direct contracting could complete the privatization of Medicare. Under the currently, prior to the DC and this REACH programs, we had two ways of receiving our Medicare at age 65. It was either traditional or it was Medicare Advantage. And now we're going to replace Medicare Advantage with direct contracting, and then that would complete the privatization of the Medicare program. So what would this achieve? It would violate the spirit of public health program that was at the origin of the original Medicare. It would drive larger corporate profits over better national health. It would corrode the value of public health plan by expanding opportunities for profiteering, and it jeopardizes the future of Medicare, and ultimately the belief that we could have a national program to pay for care for everyone that we call Medicare for All. So the third what is, well, what can we do? In November to December, physicians met with, or they delivered, they didn't actually meet with the Secretary Becerra, but they delivered to him a multitude of petitions that they had collected requesting that the program be stopped. Now, because it's purely an executive function, it can be stopped. It's not law. It was a trial project. And so it would just take the decision of the President of the United States to say that the program's ended. It isn't working. It's not doing what it was supposed to do. And that would end it. It does not require a congressional action. In January of this year, 97 members of Congress, after they had been informed by this grassroots movement of what was going on, they actually wrote a letter that demanded an end to the DCE, to Becerra. And then in February, Senator Elizabeth Warren held a, what do they call it? The Finance Committee hearing on this entity, so in order to make it even more public and to get it above board. And that was about the time that the DCE got changed to this new name of REACH, because the pressure was on the organizations. And then in March of 2022, the Congressional Progressive Caucus, when they outlined their, I think like 20 or so priorities, their number 2 priority was the cancellation of the DCE program. But it's not a congressional decision, it's an executive decision, because it's already part of the 2010 Accountable Care Act. In May of 22, there was more and more people, 350 healthcare and seniors groups became more and more aware. And so there was a large nationwide webinar to raise people's awareness of the program and the disadvantages of it. And there have been a multitude of articles and op-eds and letters to the editor, calls to the congressional representatives and Health and Human Services. So this is the grassroots movement. For individuals, a thing that we all can do, besides becoming more informed about what's happening with this program, is to contribute our signature to a petition that the Physicians for National Health program continue to gather, and that can be done on their website. Another thing that we can do is to write a letter to the editor describing the disadvantages that we see and helping people to even become aware of this new program that is liable to expand over a decade. And if we are an organization, we can once again collaborate with other organizations and do that through the Physicians for National Health program. And we can ask the members of our organizations to also be petition signers at PNHP. And ultimately, what I really wanted to get to was to make people aware of this website called protectmedicare.net. That is a fantastic resource for ordinary folks like ourselves to become more informed about the threat of expansion of privatization, the what, and the what it matters, and what we can do about it. I think that protectmedicare.net is a huge resource for ordinary folks to get good information. So I started out by believing in healthcare as a human right. Everyone should be receiving care and nobody should be excluded. But privatization of Medicare through direct contracting entities and ACO REACH threatens seniors, and it threatens the future of Medicare because it allows profiteering to happen through these schemes of introducing middlemen. Thank you.
Wow. Yeah.
I'll take this down so that we can talk, okay?
Okay.
Yeah.
We thank you so much. The
I don't
information.
know if he's hearing you right now.
I'm
Okay.
hearing.
Are you? Okay. The information that you have provided us goes beyond a lot of what I know a number of us in the league have been reading in the current
Wait a minute.
media.
Active member of a political campaign, yes.
Who's speaking? Okay. I don't see.
Go ahead.
Okay. What we're going to do at this point, I think, is ask our panelists to reflect a little bit from their perspective, working and as consumers of healthcare as well, on what you presented, and then open this for general discussion. So Amy, you're sitting in the first seat. Do you want to start and just tell us a little bit about what you do and your role, and what your thoughts are on what's been said here, if you have any reflections?
Sure.
Okay.
So I'm the elder benefit specialist for Ashland County, and I have been for several years. So we deal a lot with people that are new to Medicare. We educate them about what Medicare is, what their options are, what A, B, C, and D are, what a supplemental policy is, the network of doctors. My experience is that a lot of people are confused about what their options are currently. They don't understand the network of doctors, what Medicare Advantage programs are, and they don't understand all their options that are available. So sometimes we'll have people come in and they just say, we want to sign up for Medicare. They think they have 100% coverage. Plus they think Medicare has long-term care coverage too. So we deal with a lot of that. Education is a lot. We do a lot of outreach. I do throughout Ashland County. Mary Ann does throughout Bayfield County. So we deal with the changes every open enrollment period, which is right now. So we're always educating ourselves as elder benefit specialists too about the new things that are coming out. So.
Yeah, my name is Mary Ann Johnson. I work with Bayfield County as the elder benefit specialist. I kind of came and went from this role, but Amy and I have been at this a long time. I think she started, she said she's been here a while, but she's been here since 2004. No, 2003. I came in 2004 the first time.
Yeah, it'll
so.
be 20 years.
Yeah, so it has been a really long time. And so over the course of that time, you know, our role has really changed. It started off, and I would say maybe 50% of my role was information and education to folks about healthcare, and the other 50% was on the other public benefits that we provide information and assistance to people on. I would say that number for me is easily more like 85–90%. Would you agree? In terms of education on healthcare at this point in time. So we are trained by elder law attorneys and get information and updates from them on the goings on Medicare and other health benefits. I'm talking about Medicare specifically tonight because that's kind of our topic. But Amy's right. A huge amount of what we do is public information and education. People come in and they think it's just a one-step process. I'll sign up for Medicare and I'm done. They don't realize that Medicare only covers about 80% of the things that traditional Medicare covers. They don't realize there's a whole nother option with Medicare Advantage plans. People are inundated, completely inundated with marketing materials. I think everywhere you turn, there's marketing materials being put out there by typically Medicare Advantage plans. But when people sit down and try to match things up and make sense of it all, it gets very confusing. So a large part of our role is really trying to help people unwind and understand what your options are and what the pros and cons of the different options are. So that's a big part of what we do. We're right in the middle of open enrollment right now. So we did leave the office a little while and we'll probably go back there. No, I'm kidding. We're not chained to our desks yet. Maybe by the end of November. But right now people are looking at prescription drug plans and advantage plans and trying to make decisions on what their best option might be for next year if they've selected those options for healthcare. So it is a busy time of year, and that's really what we spend the majority of our time doing, is trying to help people understand options. So yeah, that's what we do.
And the mention too of the elder population in our counties are increasing considerably. We do get a lot of people that are just turning 65. So the education is more than when I initially started to.
Definitely.
You know, when I hear that story, when I hear that story, it just confirms for me the anguish that people unnecessarily go through because they're worried, they're concerned, am I getting the right plan? And it's all confusing. And then in the end, it's like, well, did I do the right thing? And you say, well, why do people have to suffer that way? Why do we add that layer on? And someone once told me that it's real easy to figure this stuff out, is all you have to know is what your disease is going to be and what kind of care you're going to need.
Or if you have a crystal ball,
Doesn't.
you always get that.
Just pick
People
the
always ask,
plan
well,
that
what's the
covers
best
that
option?
one.
And I don't have a crystal ball. So
Yeah.
I can't, that's
Right,
what I tell them. I said,
exactly.
listen, if I had a crystal ball, I could tell you, but I don't know. I don't know what your
You
best
see,
option.
and so because people can't, then they're caught. They say, well, do I just get a really, really expensive plan that can cover any option, or do I throw the dice? We should just have one plan. And then the other thing that we have to recognize too, because we are in this season where we could opt out of our Medicare Advantage program, if we're in a situation where we're getting some really serious illness and the plan is starting to limit our options and say, you can't go to that specialist because they're out of network and it's going to cost you a lot of money, or you can't have this particular medication because they come up with some excuse. And then by that point you say, well, I don't like this Medicare Advantage program anymore. I want to go back to traditional Medicare. And so now you have to go back from Medicare Part C to Medicare Part B, A, B, and you can't get a Medigap, or they won't sell you a Medigap because you have to buy the Medigap, which is the plan, that the insurance policy that's going to cover for the shortcomings of the original traditional 1965 plan. Why don't we just take the 1965 plan and fix it? Because we're 57 years later. I mean, times change. So add the hearing, add the vision, add the long term, do these things, make that 1965 plan something that is what people need today, and then we won't have to have Medigap, and then we won't have to have Medicare Advantage either.
Thank you. Sue, your reflections on what's been presented today.
Well, I found this information on REACH and ACO very enlightening because I really not familiar. I've been retired from being a medical social worker for about 8 years, so I realize things have changed a lot. But because of the experiences I had working with insurance companies to help patients, I have never been a fan of Medicare Advantage and have never saw, although they offer a lot of great perks, which can change over time, I just never felt it was worth it, especially as we get older and we develop more chronic illnesses and more acute illnesses. I just never felt it was worth it, and I still feel that way. A perfectly healthy person probably could do very well under Medicare Advantage, but that doesn't always last. And for me, the traditional Medicare plus a Medigap plan has always been the option that I've chosen. And I've depended a lot on the benefit specialist to fill me in, especially initially when signing up for Part D for the medications. And that's where I really, because I have diabetes and some other medical problems, the medications that I'm on almost become prohibitive to pay for, especially when you're in the donut hole and then you get out of it, you're okay for a while. But I was very happy to hear that they're going, and I guess it's 2025, they're going to limit your out-of-pocket in Medicare to $2,000 a year, which would be just wonderful compared to the thousands that I'm paying right now. So I turn to resources like the Medicare booklet that they send out every year. There's a lot of information in here, and you sort of have to pour through it and reread it and figure that out. And now with this ACO or REACH program coming about, it really upsets me that we may all get sucked into that program, which, you know, if you can't pick your doctors, if you can't make your own referrals to specialists and pick them, if you're travel a lot in the United States and you get sick and you're on an Advantage plan, there are no preferred providers in your area, you could end up spending a lot of money. I recall when I was working, and this was many years ago, but there was a woman from Arizona in her 80s. She loved her Medicare Advantage plans. They gave her all sorts of perks out in Arizona, and she just loved it. Well, she flew out here to visit her daughter, and unfortunately, she fell and broke her hip. So naturally, as a discharge planner, we were trying to see what coverage she had for her, for fixing her hip. And when I called them, they said, well, what you have to do is you have to put this elderly woman on an airplane and send her back to Arizona, and we'll pay for that. For not for the plane, but for the repair. And I said, but she's not capable. She's in her 80s. She's got a broken hip. She's in pain. She can't fly back. She couldn't even travel in a car. So, you know, that just really frustrated me. And eventually the daughter and the doctor made some kind of negotiation with the Medicare Advantage plan. They still had to pay a lot more, but at least she was able to get her surgery here instead of flying back. And that was a real eye opener for me. I don't know if those kind of things still happen or not, because this, when I was working, the Advantage plan was just coming in, I think in 2003 or around then. So we weren't used to working with those programs. And I can say I never really had a positive experience working with them as a discharge planner. And it's always made me very skeptical of signing up for anything like that.
I can tell you that it still happens. I take a lot of testimony and stories from people, and there's people, so a lot of seniors are snowbirds. And when they're selecting their plan, they don't necessarily think about that complication with their network, and they're going down to Florida, Arizona for a couple months, and they're running into problems when they go down there. And then another thing that happens when you're living in a state that has a lot of seniors in it, so then you're competing with them to try and get in to see your doctor, and you're also limited by your network. There's Henderson, Nevada. There's a big problem in Henderson, Nevada. Seniors can't get into their doctors because there's so many seniors, and then to put the filter on again that you're limited by your network, they're all competing for a limited number of slots. So that's what's happening a lot in the Medicare Advantage. But I understand 100% how seniors can be attracted to those. My own parents are on it right now. So I understand, like, seniors can't necessarily afford that Medigap plan, and they're attracted to the vision, dental, and hearing. So I get it. Ma'am, could you tell me what your name is?
My name,
Yes, your name.
Sue Setterholm.
Okay.
Yeah,
Thank you.
I've been retired. I worked about 20 years as a discharge planner, but I've been retired about 8 years, and now I'm approaching my 80s. So, you know, this is becoming very personal for me.
Yes.
And
Yeah.
I'd like as much information as possible.
Yeah. Well, thank you for sharing your story.
So, and Sue, I just needed to add one more notion here. Sometimes it's always confusing, these DCEs and REACH and ACOs and all of that. But these contracting, designated contracting, and the REACH project, it does not have a network. So that's definitely different from Medicare Advantage, which does always limit your advantage. So you could be aligned into the program because your doctor becomes aligned into the program. Your primary doctor becomes aligned into a DCE. Then the patients of that physician are automatically aligned. If they don't want to be aligned, they have to find a different doctor. But if they need specialty care, they can go somewhere else, or they can travel, and they can do that. Those bills will be paid by Medicare, traditional Medicare as always. And then they're going to come back and be reconciled with the DCE and say, hey, one of your beneficiaries traveled down to Florida and they cost us a lot of money. So because they're aligned, that patient's aligned with you, you have to pay it back. And so you could see how the financial incentives are to somehow encourage your beneficiaries not to do that. Like even the doctor might, I'm just making this up now, the doctor says, I don't think traveling to Florida is such a good idea for you. No, I'm making that up, obviously.
Yeah.
But the point is that it's just putting in these mixed incentives. You know, the physician should have only one concern, and that is how to maximize the treatment, the advantages of a treatment plan for you, my patient. It should just be clear. That's what I went to medical school for. I don't want somebody sitting in the room with me trying to dissuade me not to order a test because it's going to cost the organization too much money. And it could be subtle incentives, you know, it's just putting people into these moral dilemmas that they don't need to be in, because the physician and the care provider, the advanced practice care provider, they should have one thing in mind, and that is what's the best thing for my patient. And then the payer pays, you know, they just pay for it. You know, I don't have to argue with them. And one of the things that when you're in a plan where there's a middleman is that when there's a question, you're going to have to get an approval, or you might have to make a claim, and you might have your claim denied. Well, it's very easy and it's very common for the first time you make that claim to be denied. It's just like, you know, the first time you asked for it, you were going to deny it. And you say, oh, okay, well, I guess they wouldn't pay for it. It wasn't covered. Unless you say, no, it's supposed to be covered. And then you go and get on the phone and spend hours or whatever, go bug your doctor to spend hours on the phone. And eventually somebody says, oh, yeah, that should have been covered. But you see, the first move was to say it wasn't covered to see if you just forget about it, you know, and it's just stupid and also unfair.
Well, thank you. What I'd like to do at this point is open the discussion. And I see on the screen that a lot of folks have their mute on. And so there is an option of just everyone doing their mute, and that could be confusing. There is a reaction button on the bottom, I believe, that would give you the option to
Just
raise
put
your hand.
up, yeah.
Put your hand up, and we'll take your questions. So questions, anyone? Yeah.
I thought I noticed last year when we got our Medicare book in the mail, that a very large portion of the book was Medicare Advantage programs. And I was immediately offended. I was like, why are they promoting Medicare Advantage when this is a Medicare book? And I'm just wondering if that's part of that marketing plan to make, kind of normalize it as a part of what's optional for people without separating it out. So you really know the differences between the programs. Does anybody have any thoughts about that?
Dr. Newman, you had an answer or response?
Yeah. I had a brief conversation with the congressman from 3rd District, I guess, Mark Pocan. And he pointed out that there was an interest on the part of the legislators in the Congress to pass a bill that would remove the name Medicare from the Advantage programs. And maybe, I don't know, I didn't go into details with him, but it might maybe take the name Medicare off of the drug program as well, the Part D, because a lot of people are confused by that. I mean, Medicare Part C, Medicare Advantage, is a publicly funded privately managed healthcare insurance program, you know? So you're taking, it's like vouchers, you know, in some ways, you take public funds and then put them into private administration. And so like, I think the congressman would have been explaining then, well, let's just stop calling it Medicare. Let's call it something else. We can't use that name because people, the original program, Part A and Part B, was passed in 1965, and that's what we should know as Medicare.
Interesting. Thank you. Other questions? Anyone on the Zoom have a question? Anne Chartier.
Thank you very much. This is quite fascinating. And I too feel very strongly that what we need is Medicare for all and find this very scary. I'm curious about why we've even allowed, it seems to me that there must have been a lot of lobbying to allow for Medicare Advantage to even become an option. And our biggest problem when it comes to healthcare seems to be the insurance companies that act as intermediaries. So I guess that's pretty obvious, but just the fact that was mentioned earlier that Medicare is promoting the Advantage program, and that's where I'm not sure, you know, what's the benefit to the government of all that? I was fascinated to see the numbers, you know, the overhead that Medicare deals with, and then the other. I realized that in general, Medicare doesn't perhaps, and you alluded to this, pay enough. But the one thing I'm asking is there are a lot of people, and I consulted one before signing up for the traditional Medicare. It was pretty obvious to me that I didn't want the Advantage program. But I don't feel my advisor was negative enough about the Advantage program. And I am thinking that he must get more money if I were to sign up for that one. Do you have any opinion on that?
I can, well, if you've seen one Medicare Advantage program, you've seen one. There are a multitude out there, you know, and they're all doing, and that's what's confusing for all of us when we look at them. And some of them, as Sue said a minute ago, you know, if you're perfectly healthy, you're probably pretty happy with your Medicare Advantage program, you know, because, you know, now they might help you out with your hearing aid or whatever package they're giving you for some price. The problem is when you go outside of that package, then you start running into all kinds of disadvantages. And some of them are, you know, I think you don't even pay a premium. Sometimes you pay a premium for Medicare Advantage and sometimes you don't, depending on what kind of bells and whistles they're adding into the program. And I just keep going back to the same thing, that why don't we just fix the Medicare program? You know, just fix Medicare. Why do we have to keep trying to fix it by letting profiteers come around the edges and take advantage of an insufficient situation? So in 2003, I imagine there was a huge amount of lobbying going on, and the lobby in Washington, D.C. is huge, and it's very profitable. It's very profitable for the insurance industry to spend lots of money in Washington, D.C. because their $1 million becomes $1 billion if they can sway the bill to go in their advantage. And so it's just a good way for them to spend their money trying to influence the legislative process in Washington, D.C. For this particular DCE and REACH, however, they did not have to get involved directly, but there was a lot of interest on the part of private equity, Wall Street, because they could see, you know, 30 million traditional Medicare beneficiaries out there. If we can throw a middleman in there and set up a bunch of these DCEs, these entities, just invest in them, there's a lot of money to be made there. So they didn't even have to lobby Congress because it was already implied as a possibility under the Affordable Care Act. And the reason it was in that Affordable Care Act was because of that CMMI, the Center for Medicare and Medicaid Innovation, just a program that's supposed to be testing out different ways of improving value of Medicare and Medicaid. And under the prior administration, the director of CMMI just happened to be, by the way, just saying, a college friend of the president's son-in-law.
Well, thank you. Thank you for adding to Ann's observation. Christy, your hand was up next.
Oh, you're on
Oh,
mute.
Christy, you're on mute.
Thank you, Jan. First of all, I want to,
Oops, now we can't, you're gonna have to repeat what you said. We can't hear you.
odd.
Now I can hear you.
Okay, I turned up my sound.
Okay, thank you.
Thank you, all of you, and Dr. Newman. This presentation has actually brought to light things that are even worse than I had thought about Medicare.
She needs to be closer to the mic.
Okay, Christy, can you get closer to your mic? Nope.
You know, I'm going to switch. I'm going to come back to you. I'm going to switch devices.
Okay. Alrighty.
Leanne has a question.
I do know, well, recently there've been a number of press releases about the fraud that's occurred. And it's something like of the top 10 insurance companies working with Medicare Advantage, 6 of them have been found guilty of fraud. There's been demands for payment back to the Medicare system. Could someone just briefly address that issue as we wait for Christy to get back on?
Leanne has a
I
question.
sure can. So yeah, that's something that's been going on for 2 decades now. They're just getting more and more efficient. And there are reports that just came out. New York Times, the New York Times just published a nice article about a week ago reporting on that. And those fines, they could be just considered cost of doing business, because you make so much money by this upcoding process that, oh, darn, I got my hand slapped. I'll just have to pay a fine. But man, the take home is way more than the fine.
Mhm. Are we still waiting for Christy?
Is that better now?
Yes, go ahead, Christy.
Can you hear me?
Yes. it's
Okay.
good.
So I was just thanking all of you because this is an eye-opening presentation in many ways. To Ann's point, I was just on Medscape yesterday, and I actually, Jan, sent to you the article. It was an interview with an insurance broker who runs a senior savings program out of Massachusetts, and he signs people up for Medicare and Medicare Advantage supplement and Medicare Advantage programs. He says he gets paid sometimes twice as much to sign someone up. It depends on the state that they're in and the plan, but to sign someone up for Medicare Advantage than he does to simply sign them up for a supplement. And he gave examples and costs and so forth. He personally felt there needed to be much more transparency, that brokers tend to focus on the positive aspects of an Advantage plan. And he listed the many disadvantages to that type of plan. So I thought that was horrifying and interesting.
Thank you. Thank you for sharing that, Christy. For those folks who are here live, we do have some small sheets that reference a few of the articles that are being discussed now, the New York Times and such. And they will be up and posted with the recording on the League chapter website as well. So for people who are on the Zoom. Leanne, you have a question.
Yeah, I was wondering, as you're talking about lobbying and the power of the insurance companies and some of the big lobbies to affect this, where does the AARP, where do they fall in this? Are they on the side of the insurance companies or are they on our side? You know, have you seen any evidence of if they want this to happen and they want everybody to, you know, they're actively encouraging people to, you know, go into the REACH programs?
You know, I actually have no information on that. I think the our what is it, AARP has a Medigap plan, an insurance plan that they offer, but I really don't know. Maybe Karen does.
Yeah, actually, I'm unclear if ARP is doing any education around this particular issue. I'm not sure.
I have seen materials from ARP, and they have been, as an example, very active on the whole legislation having to do with negotiating medication costs. They do have, from what I can see, a pretty powerful lobbying arm to protect seniors. They do have a Medigap policy. I don't know a whole lot about it, but I know on the issues like medication negotiations, they're very strong. So I don't know if that helps, Leanne, but good question. Thank you. Other questions?
I have a question.
Yeah.
You know, sometimes when I go to the doctor, I get the EOB after the fact, you know, oftentimes much later. I just go once a year or so, but I noticed that the coding for what was, I just go for a physical exam, and I noticed the coding is a lot more detailed.
Yep.
And then what was really discussed, and there's all kinds of things in there that, you know, they seem like sort of exaggerations. You know, I'm just wondering, you know, I'm just on a regular insurance plan with Social Security, pays most of it. And then so much of it, in fact, the insurance company doesn't make their 80% requirements. So they have to send money back to me every year. So, but I don't know why they code things that he never says I have. You know, I'm always okay, but then I read the report of his notes and it looks, you know, looks fairly dire. And I wonder what's going on there.
Well, and Dr. Newman, I welcome you to address this as well, but as a retired provider, Medicare plans do not pay for prevention or physicals. And so we have to come up with, I mean, we want to see you. We want to keep you healthy. That's kind of a goal here, is we want to keep healthy people healthy. And as Dr. Newman has said, you also want to provide the best care for the people who have developed some chronic illnesses. But if you code it as a preventative care visit, it will not be paid for. And yet we want to make sure, we want to be able to talk about what your diet is like, how's the exercise going, you know?
You mean Medicare won't pay for it?
Right.
But see, my insurance company should pay for it, you know, because I have that coverage. So that's why I'm wondering why they do that.
I'm not sure, except that I don't know your age, but it may be that the folks in billing departments are saying this person's, you know, 65, and we know typically 99% of the people are on Medicare and they will not pay for that type of visit. So You just kind of
Well,
fall. into the-
Medicare won't pay for it, but what do I care? Because I
Yeah.
have a platinum insurance plan.
Yeah,
So they're just paid for,
yeah,
but they don't pay for it. And Medicare ends up paying a lion's share of it. And then so much so that they don't meet they have to, I think I'm correct, they have to meet an 80% amount of care. So that leaves them 20%. You were saying that it's 40% for some of these Medigaps, but I think for everybody else, it's 20%. And they haven't met that, so they have to pay me back my part of my premiums. My wife and I get we get $1,600 back on premiums every year because they don't meet that. Medicare is paying the tab, the insurance company's not.
mhm. Wow. Any thoughts?
Under the Accountable Care Act, insurance providers had to keep their medical loss ratio greater than 80% for individuals and 85% for group plans through employers. So I'm not sure, Roger, what exactly how that plays out for you, but the notion that your diagnostic list gets more complicated, it could be just a way of making you look like you need to come in for treatment so that, right, you would be evaluated as, always depends on the details, doesn't it?
Mhm.
But it really shouldn't be that way. I mean, this is the real aggravation. I've been an activist, so to speak, in this whole field for several years now, since I retired, or even before I retired. And the thing that aggravates me the most is that this relationship between the physician and the care providers and the patients, you and me, is just sacred. That is so fundamental to our human natures that we want to be able to trust the person, that we can talk about things that maybe we're afraid to talk to anybody else about, the things that are most frightening to us as frail human beings. And we go to our healers and we want to be able to trust them. And we don't want to have to second guess, whether they're getting pressure from some financial entity or some middleman sitting in the corner or anything else. I think that is the real villain in the room. And it's the strongest reason that I believe that we should just have a publicly financed, nationalized, single payer, that you go see your care provider, they need to be reimbursed for the service they provide. They put that in. They don't even have to talk about all of these shenanigans with getting approvals or making your diagnostic list look right so that you can get payment. That just seems putting the cart way before the horse.
If I could add to this, in terms of running up the cost of healthcare in our country, as well as contributing to burnout, COVID didn't start it. It accelerated it, but it didn't start the burnout. The burnout comes when you as a healthcare provider are on the telephone waiting for the insurance company to answer the call so that you can advocate for a treatment plan for the patients. And so I'll be honest with you, at the end of my career, the last few years, I got pretty snarky and with insurance companies. And I just figured, what have I got to lose? I retired, I was almost 68. And so, I just thought, well, I don't have much to lose if I get canned for doing this. But I would tell the insurance company, well, you can do that. You can make the person go back from the antidepressant that has prevented them from being inpatient in behavioral health and committing attempted suicides. You can do that, and we'll step back from the medication that's working and the treatment plan that's working. But then, are you going to pay for? And I'll start outlining that. And that takes time. That takes time. And there's a lot of good healthcare providers in our country who are spending hours on the phone advocating for patients and finally getting what the patient needs. But you know what that means in terms of burnout and healthcare costs? It really is outrageous. And I
It's
know I'm
actually the
not
number
only
one. It's actually the number one reason why people leave the profession is their burnout from fighting with the insurance companies.
Yeah.
So your experience is not unique.
No.
I'm kind of wondering what you ladies run into on a day-to-day basis, the kind of issues that you have with insurance or with just talking to people about these issues.
Sure. Well, in terms of medication coverage, people will call and say, well, I got put on a new med and I went to go pick it up and oh my gosh, the copay was $200 and I had no idea it was going to be this high. And then you have to go back to the basics of trying to explain how there's different phases of costs that you go through as you accumulate costs with Medicare Part D and you're in the deductible phase. And after you get through the deductible phase, this is what it'll look like. But so for medication, if people are prescribed a new medication during the year, that's a really confusing thing for folks. It's not always as clear cut as one would hope. If people are on a Medicare Advantage plan, I had a lady call me yesterday and she's been prescribed physical therapy and I looked online and the nearest PT that I can find to where she lives is in Grand Forks, North Dakota. Now, clearly that's not an adequate provider network for Bayfield County, Wisconsin. But that is the only provider they have listed in their provider network. So I'm hoping there's another provider that's closer. I asked her to call her physician and talk with her physician and explain the situation and call the insurance company and call me back. If there wasn't, I'm hoping that whoever was supposed to have developed that page of the book just didn't submit it in time. But that's the only thing that's listed. So things like that happen when people are, prescribed something. When things happen out of the ordinary and you're in a Medicare Advantage plan, that's when people are calling us or things don't get covered.
Is there anything that you can do?
You can appeal things, you can have grievances. I mean, there's kind of a variety of things that can happen.
So you can advise people then?
Sure. I mean, our role is to be impartial education providers and to try to help folks advocate. So that's our role. So anytime we can do that, that's what we're doing.
And another thing that I run across too is I get a lot of calls from the social workers up at the hospital telling them that, these people are in these advantage plans, but now they have to go to a skilled nursing facility and nobody in our area is part of their network and they want to get out of that advantage plan. Well, there are only certain times a year you can get out of the advantage plan and they don't understand those enrollment dates or those times that you could make coverage changes. So they're kind of stuck. Do they go home without services? Do they go into a skilled facility and have to pay privately because their insurance isn't going to cover that? So there's care issues too that we have to deal with and education about, this is the plan you're in and we can see if you meet different special enrollment periods to try to get you out of that. So that's what I deal with too. Those are, people are under a lot of stress to begin with. Families are under stress. We try to do what we can to help them relieve some of that from them, but sometimes it just nothing we can
You're
do.
up against the wall.
And one of the things that happens when you go from Medicare Advantage plan back to traditional Medicare is that then you want to also purchase your Medigap insurance to fill in for that 20% that's not covered under the original 1965 plan. But now, because you're not an original initial enroller, you may not find an insurance provider because you've got too many chronic illnesses or something. And so you may not be able to find. Whereas when you were the original inscriber into Medicare, you could. But now because you're a sort of a secondary, you may not, or it may be a costly plan that if you'd been able to enroll initially, you wouldn't have been that disadvantaged. But that's a real scary thought too.
That's a good point, Mark. I know that people will often, they hear a lot of talk about you can't have a pre-existing condition held against you, but that does not apply when you're in the area of Medigap plans. I hear that a lot because that's a lot of talk that happened around the ACA in the private market, and that's true. Pre-existing conditions can't be held against you in that part of the market, but that has not been extended into the Medigap plans.
So why don't we just fix the 1965 Medicare legislation, make it the program that people need today, get rid of Medigap, get rid of Medicare Advantage, just do the right thing.
We're here for education, but we also have a little bit of agenda, if you can tell. So
Yeah, which is fine, but I mean, from a practical standpoint, there's been a lot of water down the river since ACA and the 90s when this discussion sort of started politically, and the huge amount of money that's just gotten larger and larger now. And given our politics, is there, it would be great if we could just fix it. But at this point, we're looking at just preventing it from getting worse. What course of action is possible? Are there courses of action that are possible? What are their directions? Other information, I think, is powerful because people need to understand this. But beyond that, I mean, what kind of things can be done?
Well, as a former organizer, I can answer this.
Go for it.
The kinds of things that need to be done is we need to make sure that we're talking to our friends and our family, and we're educating them about this, and we're educating them about who to follow that is talking the talk in the direction that we want to go, and make sure that everyone is speaking out and everyone is being involved and everyone is voting. League of Women Voters, right? So that's my pitch about what you can do. Like, it is possible that you can bond with other people and move something and build a movement to fixing this. And I'm going to say you're not alone. I just saw this is embargoed. It's coming out. It's confidential, but it's coming out in the next few weeks. And I don't think it reveals anything that is groundbreaking. So I'm just going to tell you, there's a survey that just took place in Wisconsin, and we're going to be releasing the results soon. And almost 70% of people, when they are talked about the healthcare problems in our country, almost 70% of people want government to fix it, want a government-led fix. They're not for privatization necessarily. So we might talk ourselves out of that. Those people on the other side don't agree with us. 70% is a pretty high number of people that want the government to step in and to fix this problem. So
thank you, Karen. Leanne, you had another question?
Yeah, this is Lee again. I just wanted to make the comment that it would be interesting to know how many of the Washington legislators that are going to be the ones voting for this stuff to get enacted also own stock options with insurance companies.
That has been an issue, and I know discussed in the House, and it hasn't gone very far. Up here, this was just announced in the last week. The Marshfield Clinic is having discussions with Essentia Health out of Duluth, which is another mega system, and they're talking about a merger. Now, this brings up the question, who is and how do we inform the public and empower the public to have a voice in this accelerated conglomeration of the healthcare systems that are more likely to come to an agreement with the REACH? I mean, what role, this is beyond the physicians working within the system or the nurse practitioners or PAs. It's going to be put upon them, just as it's being put upon us as the patients. So how do we approach that?
Well,
Mark, I'm unclear on the mechanism that they approval for some of these acquisitions and monopolies that are taking place. Are you more familiar with that?
you know, my participation in the healthcare industrial complex was not in the C-suite, you know, it's like those decisions are being made above my pay scale all the time.
Yeah.
It's, guys, it's just so sad. There is just so much opportunity to make money on our healthcare needs. And there's a lot of calculations that are going on, how to do that best. And I think, you know, we made allusion to the fact that those who are actually doing the work of providing those cares are feeling burned out, or feeling, they call it moral anguish or moral disconnect. One time I was in a much lower level conversation with, I was working in a hospital as a hospitalist, and we were meeting with one of the financial people for the organization. And they were, you know, grinding away on the financial realities that were saying that, for example, we didn't need to get another doctor so that we wouldn't have to work 55 hours a week, but maybe have a more normal work week and so on and so forth. And then I said, you know what? The people that come to this hospital, they come for the people sitting on this side of the table so that we can do our job. They don't come for you. The bean counters on that side of the table. I didn't win any points that day. Yeah, they kind of like, they didn't like that smart mouth there.
I bet not. Do we have other questions? It strikes me that Amy and Marianne here there's so much change going on that I would compare it to what's happened, at least in the state of Wisconsin, with our municipal clerks and those folks who are sitting at our polls and trying to assess who can vote and who can't vote with all the changes that have gone on. You guys are in that same position. There's so much going on and you're trying to do the best you can. And it's a moving target, you know? So I need to say that to you. Thank you both. It's hard work. It's hard work.
Challenging.
Yeah.
It is.
Yeah.
We're never bored.
I-
No, we honestly, I mean, we enjoy our jobs or we wouldn't be doing what we're doing.
Yeah,
And it is really rewarding work and it's important work.
Mhm.
So
definitely.
it's important to give people good, accurate information so they can make good decisions.
Oh, definitely. So before we close, I want to thank everyone here for the panelists and the folks with Citizen Action for taking the time to spend with us up north. You're missing some good color. Just to the east of us, they had a foot of snow. We didn't see that. We still have a lot of color. And if you come up north, you'll have to stop in and visit us. So thank you so much. And for all the participants on this program, it has been recorded and will be put on the League of Women Voters website, Ashland Bayfield County. So you could share it with your friends. The advice that Karen had to talk to our family, to talk to our friends, I think is critical. We need to get the word out on what's really happening here. So thank you, everyone. And you have a
Thank
good
you for
evening.
having us.
Yeah, thank you.
Thank you.
Thank you so much. Thank you.
Thank you.
Bye-bye.
Thank
See
you.
everyone.
Bye.
Wow.